Buenas tardes a todos. Gracias por acompañarnos. Estamos nuevamente en un webinario de la Asociación Mexicana en Ultrasonografía Crítica y Urgencias con su Unidad Internacional de Entrenamiento en la ciudad de Guadalajara, Jalisco, México. En esta ocasión estamos verdaderamente honrados por tener una invitada excepcional desde Italia, desde Pavia, Italia, la doctora Silvia Mongodi, quien es intensivista y está trabajando en una fabulosa unidad de cuidados intensivos allá en Italia. Ella pertenece, de hecho ella ya ha estado aquí en México en algunos cursos, igual que algunos de sus también integrantes. Hemos tenido la oportunidad de participar con ellos en algunas certificaciones y demás. Y la doctora Silvia pertenece, como ustedes han podido ver en la promoción, pertenece a un fantástico grupo que es el grupo GRIP, que es un grupo de investigación en cuidados intensivos. Es un grupo de intensivistas allá en Italia fabulosos que se han dedicado a innovar y sobre todo a investigar y publicar. Ustedes pueden ver, seguramente en algún momento han podido leer muchos de sus artículos porque han escrito temas muy interesantes, sobre todo de ventilación mecánica, de ultrasonido pulmonar, de diafragma, de ecocardiografía y su aplicación en el día a día de los cuidados intensivos. Han escrito excelentes y maravillosos artículos que ustedes pueden ver en el sitio de grip-org. Están ustedes invitados a visualizar y a visitar este sitio. Es excelente como medio de aprendizaje. Y pues bueno, la doctora Silvia nos ha hecho el grandísimo honor y el favor de acompañarnos en este webinario con el tema de ultrasonido pulmonar para el diagnóstico temprano de la neumonía asociada a ventilador. Esta conferencia está basada en una precisamente de sus publicaciones junto con otros autores sobre la utilidad del ultrasonido pulmonar ahora en el diagnóstico temprano de neumonía asociada a ventilador, que es un tema muy popular, muy candente, porque para todos los que manejamos pacientes críticos, bueno, pues es algo que estamos todo el día analizando, todo el día estamos manejando este tipo de pacientes y resulta sumamente práctico. Así que démosle la bienvenida a la doctora Silvia. Y pues en este momento vamos a iniciar. Les agradecemos su compañía. Como ustedes saben, pueden participar a través del chat de Facebook o bien a través de nuestra plataforma haciendo preguntas directamente, incluso con audio. Thank you so much, Silvia. Thank you for accepting this invitation. We are really honored. We are very happy, very happy because for joining us in this webinar. I'm really excited for hearing you. Silvia, let's get started with your conference. Thank you for accepting this invitation.
Thank you to you for inviting me. So let's start with the real topic, how to use lung ultrasound for the early diagnosis of ventilator-associated pneumonia.
Thank you.
First of all, what are we speaking about? The ventilator-associated pneumonia are infections developed in patients who have been ventilated by mechanical ventilation for at least 48 hours. And they are surely a relevant issue in ICU since they are more of a half of the ICU-acquired infections. And they have a very high mortality ranging from 20 to 50%. Moreover, more than a half of antibiotics prescribed in ICU are due to ventilator-associated pneumonia. In fact, the most adequate treatment relies on the identification of the germ and the introduction of an adequate antibiotherapy. As for any infection, mainly in the critically ill, any increase in the delay of the introduction of an adequate therapy may determine an increase in mortality. In general, ventilator-associated pneumonia is suspected on a patient under mechanical ventilation on the basis of clinical, biochemical, and radiological signs, which are fever, hypothermia, hyperleukocytosis, the presence of purulent secretions, hypoxemia, and eventually new or evolving opacities at the chest X-ray. So the confirmation, the diagnostic gold standard is a distal microbiological sampling which in general corresponds to a bronchoalveolar lavage, which will require 24 hours to give us preliminary results, which means just to tell us if it's positive or negative, and 48 hours for definitive results, so the definitive identification of the germ and the antibiotic resistance profile. In the meanwhile, while we are awaiting for the confirmation of microbiological sampling, we need to decide how to manage our patient. So we have 48 hours where our patient is suspected for having a VAP, but we still don't have any confirmation. And we can grossly decide between two approaches. The clinical approach relies on clinical and biochemical parameters. In this case, all the suspected patients with a ventilator-associated pneumonia will be treated with antibiotics. And we will use bedside the clinical pulmonary infection score, which is an association of all the standard clinical and biochemical parameters which are commonly used to raise the suspicion of ventilator-associated pneumonia, which means temperature, leukocytes, tracheal secretions, oxygenations, and infiltrates on chest radiograph. If I choose a clinical approach, this will mean that I will overtreat my patients, that a significant percentage of the patients that I will treat with antibiotics will finally have a negative BAL. And this may lead to an increase in multi-drug resistant bacteria. In fact, this approach has low accuracy, with both sensibility and specificity ranging around 60%. On the opposite side, I can choose a microbiological approach. So I will treat my patient only when I will have the confirmation of a distal microbiological sample positive for a germ. So I will only treat patient with a real infection, but I will necessarily introduce the antibiotic with a certain delay due to the time required for the positivization of the culture. And this may lead to an increased mortality. Which is the contribution that imaging can give in this context? We know that chest X-ray is not accurate in the critical ill because it's not specific and not sensible. We also know that lung ultrasound has already been demonstrated to be a useful tool for the diagnosis of community-acquired pneumonia. And in this case, patients come to the emergency department with dyspnea, and a very specific sign is the presence of a tissue-like pattern. So the presence of a consolidation in a patient coming to emergency department is highly specific and highly for community-acquired pneumonia. We also know that the number and the size of consolidation has a good correlation with the severity of the disease and that we can monitor them to follow the evolution of the pneumonia. And we also know that Boemad et al. Has already demonstrated that we can use lung ultrasound to monitor the evolution of ventilator-acquired pneumonia. So all this background suggests that there could be a role in the early management of the patient with a suspected VAP for lung ultrasound. And we will see in the next half an hour how to perform an early diagnosis of ventilator-associated pneumonia, also thanks to lung ultrasound, how we can improve lung ultrasound sensitivity, and we also briefly describe how to monitor ventilator-associated pneumonia. So let's start from the diagnosis. I found some recent systematic reviews and meta-analyses in literature. They cannot provide many new data because the very important thing is that they could only find 3 studies in literature focused on the use of lung ultrasound for ventilator-associated pneumonia, and most of them are affected by high or unclear risk of bias and applicability concerns. And let's see 3 of them, not just our work. The first one is a retrospective study made by Zaghi et al., focused on the assessment of the value of chest infiltrates for the diagnosis of ventilator-associated pneumonia. And when they speak about infiltrates, they consider tissue-like pattern, so the presence of a consolidation, and the presence of subconsolidation. So in one case, we have a tissue-like pattern, and in the other case, we have a small echo-poor region just opposed to the pleura and with a shred sign delimiting the echo-poor region. This first work is interesting because it suggests a role for lung ultrasound in ventilator-associated pneumonia diagnosis. The authors try to compute a new score, which is the chest echograph and procalcitonin pulmonary infection score. So as you can see, they replaced the chest X-ray of the CPAS with infiltrates on chest echograph, and they also introduced procalcitonin. I think it's important also to remark that in the score, we have the culture of tracheal aspirate, and we will see in a few seconds why. The performance of this score is significantly higher than the CPAS in the diagnosis of ventilator-associated pneumonia. But we have some methodological issues of this study. The first is it's a retrospective study, and that they used criteria for the ventilator-associated pneumonia, which is not exactly the gold standard. They use quantitative endotracheal aspirate, which can be accepted, but not with the same cutoff that they used. And this same parameter, quantitative culture of endotracheal aspirate, was also integrated in the new score. So, of course, the new score was very performing. And moreover, they consider positive also the endotracheal aspirate with Candida albicans. And finally, we cannot consider a quantitative endotracheal aspirate exam an early diagnosis because it requires 24-48 hours as DPAL. Moreover, they used exclusion criteria that aimed to rule out all the problematic patients. So they ruled out all the patients with potential other sources of sepsis, COPD decompensation, and ongoing antibiotherapy. This limits the generability of their results. And finally, we will see that they used lung ultrasound parameters that are not very specific in the critical ill. The second study is an observational cohort study by Burley et al. They monitored for at least 5 days all the patients that were considered at high risk for ventilator-associated pneumonia. And they focused on the consolidations pattern, which means the presence or absence of bronchogram, if they were dynamic or static, and if the Doppler gave any signs. And there's a signs of the meaning of a dynamic air bronchogram. However, also this study presents some limitation. The diagnostic confirmation in this case is made by endotracheal aspirate OBAL, but with a semi-quantitative analysis. And mainly with lung ultrasound, they only focused on the tissue-like pattern, and therefore they examined only 2 areas per hemithorax, 1 lateral and 1 posterior. And finally, they only had 12 ventilator-associated pneumonia patients, so a very little sample size. The third study is the study made by our group, and it was a prospective multi-center international study involving Pavia in Italy, Paris in France, and Montreal in Canada. We examined all the consecutive patients with a suspected VAP, so a suspected ventilator-associated pneumonia. And the suspicion was based on the criteria suggested in literature, so at least 48 hours of mechanical ventilation, newly appeared or evolving infiltrates on chest X-ray, and at least 2 clinical criteria, among temperature, either fever or hypothermia, leukocytes, either hyperleukocytosis or leukopenia, the presence of purulent tracheal secretions, and an impaired PaO2 FiO2 ratio. We excluded very few patients, those with an already ongoing pneumonia, and patients with contraindication to fibrobronchoscopy, which means patients that were too hypoxemic to perform a fibrobronchoscopy and to receive a bronchoalveolar lavage. In each patient, we performed the CPA score, so the score combining clinical and biochemical signs and chest X-ray. We performed a bronchoalveolar lavage, providing within 48 hours, after 24 hours preliminary results, and after 48 hours definitive results with the cutoff suggested in literature. We also performed endotracheal aspirate, and in this case we performed both a gram stain examination. The direct gram stain examination provided a result within 2 hours, and in some cases could be performed at the bedside in the ICU. And on the same endotracheal aspirate, we also performed a quantitative culture with a different cutoff as for BAL, as suggested in literature. In almost all patients, we also had procalcitonin, and of course, we performed lung ultrasound. And when we performed lung ultrasound, we examined all the 12 standard areas, which means 6 per hemithorax, 2 anterior, 2 lateral, and 2 posterior areas. And we focused on 2 signs: the presence of subpleural consolidations and the presence of an air bronchogram, which had to be dynamic, which means it moved synchronously with tube ventilation and with a linear or arborescent shape, as you can see in the video. The positive confirmation of ventilator-associated pneumonia relied on a positive bronchoalveolar lavage, but we also consider, as suggested by international guidelines, we consider positive patients with a negative BAL, but meeting all the clinical criteria and having introduced or modified the antibiotherapy in the previous 48 hours. And these are our results. We enrolled 99 patients with a high prevalence of ventilator-associated pneumonia, 63 patients with pneumonia and 36 patients without pneumonia. And as you can see, there were no significant differences between the population with pneumonia and the population without pneumonia, except for the SAPS score, which was higher in the population without pneumonia, procalcitonin, which was strangely also higher in the population without pneumonia, and the presence of purulent secretions, which was, as expected, higher in the population with pneumonia. You can see that patients with pneumonia and without pneumonia are not different for the other characteristics as age, sex, BMI, previous ongoing antibiotic therapy, and also for prognosis in terms of ICU mortality, total duration of mechanical ventilation, and ICU stay. We isolated mainly gram-negative bacteria and the Pseudomonas aeruginosa. And let's arrive to diagnostic performances. As you can see, the CPAS, so the clinical pulmonary infection score, combining clinical, biochemical, and radiographic parameters, has a acceptable sensitivity but low specificity with a positive likelihood ratio of just 1.4. And you can see that the presence of purulent secretion actually has a higher positive likelihood ratio. Procalcitonin also is poorly informative because it's acceptably sensitive but very poorly specific with a 0.8 positive likelihood ratio. And we can see that the performance of positive gram stain examination or quantitative culture, of course, of the endotracheal aspirate was of course higher than the CPIS. Let's come to ultrasound results. Concerning the presence of a tissue-like pattern, so the presence of consolidations, we can see that almost all our patients had a consolidation, at least one consolidation in one area. So this parameter is very sensible in patients in ICU undergoing mechanical ventilation, but has 0% specificity because mechanically ventilated patients have many other reasons than pneumonia to have consolidated lobe, mainly in posterior areas. Concerning subpleural consolidation, the presence of subpleural consolidation in at least one area has a pretty high sensitivity, 81%, with low specificity, and the same likelihood ratio than the CPAS. So one simple ultrasound parameters, the same likelihood ratio than the CPAS score. In general, we can see that subpleural consolidations are a sensitive sign, while the presence of linear or arborescent dynamic air bronchogram is a specific sign, with an increased specificity if this sign is present in at least 2 areas, with 97% specificity. We tried, therefore, to combine these ultrasound parameters to obtain a score that could be easily applied at the bedside to our patient with a suspected ventilator-associated pneumonia to decide how to manage them in the earliest phase. And therefore, we create post-hoc the V+, ventilator-associated pneumonia lung ultrasound score, which, as you can see, is very easy to compute because it has just 3 points. We give one score if at least 2 areas present subpleural consolidation, 2 points if at least one area present one dynamic linear air bronchogram, and 1 point if the patient has purulent secretions. We also computed the V+ score enhanced by the gram stain direct examination and the quantitative analysis of endotracheal aspirate, thus generating 2 additional scores, the V+ EA gram and the V+ EA quant. And we compare them to what we only use at the bedside to compute the risk of our patient to have ventilator-associated pneumonia, so the CPAS. And you can immediately see that the CPAS is much harder to compute because it's much longer and more difficult to remember. And we compute the CPAS, and also for the CPAS, 2 additional versions enhanced by the results of gram stain examination and quantitative analysis of endotracheal aspirate. And these are the diagnostic performances. We have run the CPAS with a positive likelihood ratio of just 1.5, average sensitivity and low specificity. The sensitivity is increased by the association with the direct gram stain examination of the endotracheal aspirates, and the specificity is increased by the association with the quantitative analysis of endotracheal aspirates. In both cases, we do not reach a very high positive likelihood ratio. When we use the ultrasound score, when we use the V+, which means only ultrasound parameters and the presence or absence of purulent secretions, we can see that we have satisfactory sensitivity and specificity with a 2.3 positive likelihood ratio. And that this result is significantly improved when we associate the V+ to the results of a direct gram stain examination of the endotracheal aspirates, and even better when we associate quantitative analysis of endotracheal aspirate. In particular, when we use the V+, so just ultrasound and purulent secretions, if the patients meet all the 4 criteria, the positive predictive value is 100% and specificity is 100%. The same results, but it's area under the curve. In yellow, we can see the CPAS score performance, which is pretty poor with 0.574 area under the curve. It is improved by the association with the endotracheal aspirate gram, which is the gray curve. When we consider the lung ultrasound score, B+ is the blue curve. So a better performance than CPAS and a similar performance of CPAS associated to quantitative endotracheal aspirate. Of course, the performance of B+ is significantly improved by improving the association with direct gram stain examination and quantitative analysis of the endotracheal aspirate. So in conclusion, all the studies we saw confirm that CPAS has a low diagnostic performances for the diagnosis of ventilator-associated pneumonia. Our results confirm what previously described in literature, that there is no interest in procalcitonin for the diagnosis of pneumonia. Concerning the lung ultrasound signs, we found that a tissue-like pattern alone is not specific in a ventilated patient in the ICU, because almost all the patients had at least one consolidation, but we found other lung ultrasound signs with good diagnostic performances. In particular, subpleural consolidation had high sensitivity, and dynamic, linear, or arborescent air bronchogram had high specificity. Therefore, at the bedside, we can use easily to compute scores as the V+ or V+ EI-gram to decide if the patient has a high or low risk to have ventilator-associated pneumonia, and decide how to manage them in the earliest phase. Let's see how we can already improve these results, because we have seen that V+ has good performances. However, sensitivity is not perfect, and we have some false negatives results. So we can have non-specific patterns. For example, a patient with a tissue-like pattern but with no air bronchogram, that may result in a positive bronchoalveolar lavage and therefore in a confirmed pneumonia. What we can do is to check if my consolidation pattern changed after fiberbronchoscopy. Let's see these two images. For example, on the left, we see the diaphragm separating the spleen on the right and a consolidated lung on the left. There is no air bronchogram, and we can also visualize a good perfusion of this hepatized lobe, which means that this area is also surely shunting and therefore is a source of hypoxemia. This pattern is not specific for ventilator-associated pneumonia because there's just a tissue-like pattern, but I do not visualize any dynamic air bronchogram. We performed fiberbronchoscopy and checked the modification of the pattern after fiberbronchoscopy. And what we found is that we didn't see any more deconsolidation, but we saw a re-aerated lung with a severe loss of aeration, but with no more consolidations. Therefore, we could interpret the etiology of consolidation as due to obstructive atelectasis. We performed fiberbronchoscopy, we disobstructed the airway, and therefore we re-aerated the downstream parenchyma. Another example on the left, again, a pattern which is not specific for ventilator-associated pneumonia, because we can clearly see the diaphragm, the spleen on the left, and the lung on the right. Within the lung, we cannot see dynamic air bronchogram. So this is not a specific pattern for ventilator-associated pneumonia. We performed fiberbronchoscopy, and we saw that after fiberbronchoscopy, we saw the appearance of a linear dynamic air bronchogram, which is specific for ventilator-associated pneumonia. So sometimes when the pattern is not specific, because we have a tissue-like pattern with static or absent bronchogram to recheck after fiberbronchoscopy may lead to discover new findings which can help in the diagnosis of pneumonia. Just a few words about the monitoring. We know that we can compute a lung ultrasound based on the identification of 4 progressive steps of loss of aeration, going from the left, where we have a normal lung, to the right, where we have a completely deaerated lung. And Puemat et al. Show that we can compute the reaeration score in 12 standard areas at 7 days of antibiotherapy. So I performed the score at day 0 when I start antibiotherapy, and then I checked how the areas changed after 1 week of antibiotics. If the area improved, then I will give a positive score, and I will give 1 if they switched of 1 class, 3 if they switched of 3 classes, and 5 if they switched of 3 classes. On the contrary, I will give to each area a negative score if the area worsened, -1 if it worsened of 1 step, -3 if it worsened of 3 steps, and -5 if it worsened of 3 steps. And what Puemat et al. Demonstrated is that this reaeration score has a good correlation with the CT scan findings. And if after 1 week of antibiotics, it's positive and above or equal to 5, it corresponds to a successful antibiotherapy. While if it's negative and lower or equal to -10, it means that the lung is not reaerating despite the antibiotics, and maybe I have to resample my patient because there's something that is not going well with the therapy I'm giving to him. In conclusion, I can use lung ultrasound to orient my early management of my patient. So when I suspect ventilator-associated pneumonia, I will perform a BAL or a quantitative analysis of endotracheal aspirate, and I will perform lung ultrasound. And ideally, I will compute the ventilator pneumonia lung ultrasound score, the V+. If it's positive, then I will give antibiotics. If it's negative, I will give no antibiotics. I can use also the gram stain direct examination of tracheal aspirate if available to enhance my results. After 48 hours, I will have the results of the BAL, and I will therefore de-escalate or escalate my antibiotherapy depending on what I decided on the lung ultrasound findings. And after one week, I can reassess the response of the lung to the antibiotherapy I introduced. If the score is above 5, I can either stop my antibiotics or be sure that I'm effectively treating the infection. If it's below -10, then I need to reassess the etiology of the pneumonia and eventually resampling my patient. So finally, we can use lung ultrasound for the early diagnosis, computing the V+, ventilator pneumonia lung ultrasound score. We can improve lung ultrasound sensitivity when I find a non-specific pattern as tissue-like pattern with no bronchogram by reperforming the lung ultrasound examination after fiberbronchoscopy. And we can also use lung ultrasound score to monitor the effects of my antibiotherapy on the pneumonia. Thank you very much.
Thank you so much, Silvia. It was a very, very nice presentation. Thank you so much, Silvia. Let's move on to the questions. If you allow me, Silvia, I'm going to speak in Spanish for a while.
Mm-hmm.
Thank
I
you.
can understand you, but I cannot speak it.
Okay, thank you so much. Bueno, como ustedes pueden ver, ha sido una fantástica ponencia de la doctora. Nos ha llevado por todo lo que se ha estudiado actualmente respecto al ultrasonido y la neumonía asociada a ventilador. Si ustedes gustan, pueden hacer ya algunas preguntas, ya sea a través de nuestro chat de Facebook o bien a través de la plataforma. Y tenemos algunas preguntas y comentarios, Silvia, about the specific signs or lung ultrasound specific signs of pneumonia. You know, the intensivists and general, all the critical areas physicians, when we perform ultrasound, we are searching for specific signs of something, you know, the specific signs of pneumonia, specific signs of fluid responsiveness, etc. And specifically in the lung ultrasound, when we are searching for specific signs of pneumonia, do you think there are that sign, specific signs regarding a specific, for instance, type or kind of pneumonia? I mean, maybe the etiology of pneumonia. Do you think there is a specific pattern of a specific kind of pneumonia?
So do you mean a specific kind of pneumonia as viral or bacterial, for example?
For example, because there are some publications and some papers about specific signs of Klebsiella or specific signs or the specific pattern in swine flu, for instance. Do you have some experience about this?
I think it's very hard to say that there is a specific ultrasound sign for a specific kind of pneumonia. I think we should be very cautious in the use of the ultrasound, because it should always go with the clinical examination. So our study was performed on patients that were suspected for ventilator-associated pneumonia, not on all the patients in our ICU. So first thing is associating lung ultrasound to the clinical examination. And the second is that so far what we could demonstrate is just that there are specific signs for ventilator-associated pneumonia, but not for a specific etiology. So dynamic, linear, or arborescent bronchograms are specific, but we cannot say anything more. We can say that all our pneumonia were bacterial, not viral. Maybe because we didn't search for a viral ventilator-associated pneumonia, because we usually look only for bacteria when we sample patients for ventilator-associated pneumonia, while we look for viruses when we sample them for community-acquired pneumonia.
Right, thank you, Silvia. And in your experience or in your opinion, Silvia, do you think the chest X-ray is still needed in the ICU? Do you think we should perform chest X-rays in our intensive care units, Silvia?
I think it is surely less needed than before. And it has already been proven that the introduction of lung ultrasound in the intensive care units can lead to the reduction of chest X-rays. It was used years ago as a monitoring tool, while I think but it's shown in literature that lung ultrasound provides much more accurate information on the critical ill. So it is not completely useless, but of course, I think its use is much less required than before.
Right, exactly. Thank you so much, Silvia. Could you please talk a little bit more about the use of color flow Doppler in the consolidations, Silvia? Because this is something that I'm sure many physicians want to know about this specific topic, Silvia.
Well, what I showed you was a picture of a consolidation, good perfusion, which corresponds to the definition of a shunt. It's a not aerated tissue here on the left, not aerated tissue with good perfusion. So I can say that this area is shunting because it's well perfused but not ventilated. It's the ultrasound image of the definition of shunt. How there are no studies so far quantifying the shunt. So it's just a qualitative analysis, not a quantitative one. I cannot say how much shunt is determined by this consolidation.
Okay, Silvia, and do you think the presence of shunts is important to distinguish between atelectasis and pneumonia, for instance? Because the consolidations are very common in our practice when we are performing ultrasound, and sometimes we see a lot of consolidations above all in patients with ARDS and so on. And we are worried about how to distinguish between atelectasis and pneumonia. And do you think the color flow, when we visualize shunts, is a very specific sign of pneumonia, in your opinion, Silvia?
It may be, but it's not demonstrated. So the only sign to distinguish atelectasis and pneumonia is dynamic air bronchogram so far. Right. Atelectasis cannot have dynamic air bronchogram, neither punctiform or linear arborescent. Mm-hmm. So if I see a dynamic air bronchogram, I can 100% rule out atelectasis. If I see a dynamic air bronchogram with a specific morphology, which means linear or arborescent, then I can think about pneumonia with high specificity. The presence of a shunt is not specific, or has not been investigated so far. Maybe, but we don't know.
Yeah, Silvia, thank you so much. Well, there are some papers about you mentioned about the procalcitonin, and it's hard. The procalcitonin and sometimes is not so useful as you mentioned. And do you think when we are giving antibiotics, we see reaeration in the lung ultrasound, and the patient apparently has improved because we notice that the patient has a better aeration. So do you think we should stop antibiotics when we note that the patient has a better aeration?
Well, this depends on the etiology of pneumonia. So it's not lung ultrasound findings that will tell us to stop the antibiotics, but more the international guidelines on the length and duration of antibiotherapy. So I would rely more on international guidelines to decide how long antibiotherapy should last. But lung ultrasound can tell us if I'm going to direction or not. So if my antibiotics is efficacy or if I have no efficacy of the antibiotic I am giving to my patient.
Right, okay. So we have to integrate the clinical signs with the ultrasound signs as we have to do in other topics. Well,
exactly.
Exactly.
It's a useful monitoring tool. It's a useful monitoring tool, lung ultrasound, but it does not replace all the other knowledges we have, right?
Yes, exactly. Okay, thank you so much, Silvia. No sé si existiera algunas otras preguntas. Aparentemente no hay preguntas más en el chat de Facebook. Seguramente veremos más dudas en el transcurso de las horas y de los días en el chat. Y la doctora Silvia nos ha expresado su disposición para seguir comentando o contestando algunas preguntas que pudieran surgir en el transcurso de las semanas, incluso en el Facebook. Así que, pues bueno, si no hay otros comentarios, Silvia, apparently there are no more questions. We really appreciate this time, Silvia. We really appreciate. Thank you for spending part of your time with us. I don't know, Silvia, if you want to say something to all of our audience right now.
It was a pleasure to be invited, and I hope it was full. And if you have any question, I will be happy to discuss them with you.
Thank you so much, Silvia. And maybe on future we can schedule some webinars because you have a lot of very amazing papers. So maybe on future, if you are available and you agree, maybe on future we can schedule some other webinars, Silvia.
Sure, why not?
Yes.
Thank you to you.
Thank you for your group, and I am inviting to all of our people in Mexico and Latin America that you have a very amazing group, and we are inviting to all of our followers that you have a very nice group and with excellent papers and excellent research. Thank you so much, Silvia. Gracias a todos por participar. Están invitados desde luego a visitar el sitio de GRIP que tiene la doctora junto con muchos otros colegas allá en Italia. Es un grupo excelente de investigadores. Ustedes pueden ver una gran literatura sobre ultrasonido pulmonar, sobre diafragma, sobre ecocardiografía y sobre otros temas, no necesariamente ultrasonido. Ellos tienen grandes artículos sobre ventilación mecánica y otros tópicos de gran interés para los intensivistas. Ahí está la dirección en nuestro sitio de Facebook, www.grip-org. Ustedes pueden ver su fabuloso sitio y grupo. Así que, thank you so much, Silvia. Thank you for accepting this invitation. Thank you so much.
Thank you to you. Thank you again.
Gracias a todos. Nos estaremos viendo próximamente. Un abrazo a todos desde México. Gracias. Thank you so much, Silvia.
Goodbye.
Bye.